So we're very pleased to be here and to learn from you. And as Drew said, we have been seeing a lot of veterans through the Department of Veterans Affairs in the U.S. We have about 21 to 22 million veterans in the U.S. About 2 million of those are females. If you look at the distribution, interestingly, our biggest group of new veterans in the VA are Vietnam veterans. The biggest group of new people coming in. And so when we talk about health issues of older veterans and kind of the long-term downstream impacts of war, this is a lifelong consideration. And so we're happy to be with you because this is an incredibly important thing, not just in Ukraine or in the US. It's really in communities across the globe. It's important to us as a species, really. How do we support people that have been through these sorts of experiences? So this gives you an idea. Drew said, you know, this was our way of looking at kind of the challenges of taking care of veterans in the U.S. This is kind of the demographics of our veterans. And here's what we have to work with. We have remarkable resources for sure. We have more than 150 medical centers, VA hospitals in our systems, 300 vet centers. And vet centers are interesting because they started after the Vietnam War, and they were started by veterans who realized they just weren't getting what they needed in the community. And so this idea that Drew just mentioned of peer support, often veterans are the best support we have for veterans, and so including veterans in everything we do is essential. Almost 1,000 clinics that we have, you know, so we have a large system. So like Drew said, we're trying to figure out what are we going to do with these people coming back from the conflicts in Iraq and Afghanistan? And at this point, it's actually more like 2.9 million have been deployed. About 1.9, almost 2 million are eligible for VA care. Over half of those have been seen in the VA. So we've seen a lot of combat veterans. In my clinic in Seattle, there were weeks that we saw 40 new combat veterans in a week, just coming back from the front. So we know what you're going through, and we also know here in Ukraine and in other nations as well, and we know that it really takes more than anything else a community-wide effort. It really takes all disciplines, it takes all your health programs, it takes every community member working together to do this, and in a way, it's one of the most strengthening experiences a community can ever have, taking care of folks that are in need in this way. So we know what's going to come out of this for all of you is something that really strengthens your communities. So yeah, I think that was, yeah, so another interesting thing that I'll mention is that in the US we have Guard and Reserve forces also. And in the recent wars, half of the people deployed to Iraq and Afghanistan were from Guard and Reserve forces. Half of the people were deployed more than once. So they went for a year, came back for a year, and then they went back for another year. Half were deployed more than once. Well, actually, half were deployed 2 times, and about 25 to 30% were deployed 3 or more times. So these were military personnel that were going back and forth. So this issue of transition, it was transitioning back and forth between active duty and so on. So what we know is we're all in the same boat. As Drew was just saying, and as everyone has said here today, it's predictable what we're going to see when people come back from war. And actually, these pictures are from a training we did in July of 2015 of a group of psychologists here. I think Oksana is here today. We did a virtual training on Skype for kind of how to take care of people returning from combat. And initially, they were saying, how do we treat PTSD in people coming back? But what we've been talking about today is PTSD is important. We see it. It's important that we treat it. It's one piece, one small piece, really often, of what a person needs when they come back from combat. And we know that it runs across all cultures. PTSD, we see different numbers and different rates, but the truth is there's a linear relationship between traumatic experiences and a person having problems that involve sleep and anxiety and relationships and so on. So we know, like Drew said, there are similar concerns. It's predictable that the most common things you're going to see after war are physical, musculoskeletal injuries, chronic pain, which is a big issue, as has been mentioned, diagnosable mental health conditions, PTSD, depression, and so on, but also people that may have symptoms that would maybe respond to behavioral health intervention, but don't meet criteria for PTSD, let's say. So in my clinic, we did a study of a large group of about 1,200 veterans coming back, and the ones that had some symptoms of what we call PTSD, but didn't meet criteria, so you'd check the box, they didn't have enough symptoms to say they had PTSD. Their suicide risk was as high or perhaps higher. So this isn't about do they have PTSD or not. This is about how did this experience affect you and what can we do to help you. So there are predictable things. Each war will have unique consequences. And I'm gonna do something very annoying. I'm gonna go through a bunch of slides because we don't have time to spend on them. And many of these things have already been said. What we found is that the people that had PTSD and pain and traumatic brain injury or concussion from blast injuries, if you had one, half of the people had all three. So we're talking about people with a very complex presentation, as was mentioned. So we tried to figure out how are we going to break it down to kind of approach this clinically and also as a system. And what we decided was they talk about biopsychosocial model and so on. And you know, we thought, well, gosh, there are physical implications of combat. And here they are listed. I won't go through them, but these are physical insults on the body. There are psychological traumas or insults in combat, including anticipation. For a lot of veterans, the anticipation of combat is often more difficult than combat itself. Because once things start happening, your training kicks in, you do what you need to do. But there are many psychological kind of stressors of deployment, including separation from home and family, which many veterans report is the most difficult thing of all, is being separated from home. And the psychosocial, in other words, how does it affect our families, our parenting, our future employment, financial situation. So you know, what I'm going to do is I'm going to skip ahead here to, so the model, you know, just quickly, it's so interesting. We all are talking about the same thing. As veterans get older, they have more health consequences, including heart disease and cancer and mental health conditions and so on. We know that if a person has one mental health condition, they're likely to have two or even three. So what we have to think about not so much do we treat PTSD, or it's getting a sense of how this has affected a person psychologically, both in terms of diagnosable conditions, but also in terms of just having symptoms that may not meet criteria. So again, I'm sorry to do this, it's kind of annoying. It's all making the same point that when a person comes back from deployment, they have so many things going on. And so we sort of look, maybe they have injuries, maybe they have combat, non-combat, maybe they have environmental exposures. Drew's group kind of specializes in that. Maybe they have post-combat symptoms, PTSD. They need financial resources. So when you look at that, how do we take care of this? You know, how do we support a person? And what our model was, that circle is our medical center. That circle, the red circle, the big red circle, is our community. Is our healthcare system. It is tying all these things together in a way that actually works for someone that's coming back from that situation. At the clinical level, in order to sort of create a horizontal integration at the clinical level, we said, well, bio, psycho, social, we'll have a medical provider, a mental health provider, and a social worker. Everybody gets a behavioral health person. We don't screen them and then send them if they're one of those people that need behavioral health. We just built it into the system and said, everybody spends an hour with a behavioral health person, and then you got that person on your team if you need them down the road. So this was kind of the model we came up with at the clinical level, and we rolled this out in the VA in 2008. And by 2010, 84% of all these medical centers in the VA had these sorts of clinics, one model or another. They had some kind of good integrated post-deployment care. So it's not rocket science. It can be difficult to do in organizations, but that was kind of the model we came up with. The other thing then I wanted to show was in terms of horizontal integration of the system, In other words, from the primary care level to the specialty level. Drew really has been involved with these war-related illness and injury study centers. They're tertiary centers. They can spend more time. They have more expertise. They do more research. And they also do a lot of education and training. So what we tried to do as a system is what you all are trying to do in your settings too. How do we connect things horizontally at the clinical level, let's say, or at the community level? And then how do we connect things vertically throughout a hierarchical system of whether it be medical care or health care or whatever? Our mantra for post-deployment care was, when a person comes back from a conflict, from a deployment, what they really need is connection and integration. Connection because they feel disconnected from their families and from the trajectory of their life, and they feel disconnected in many ways. And they feel kind of like things have kind of fallen apart. A lot of times people will literally say, I feel like my life's kind of falling apart. So we tried to create a system that modeled and promoted connection, not just connection with the veteran, but connection with other team members. An interconnected system, just like an interconnected family, any interconnected system is going to function more effectively. And integrated so people are connected, and they put the pieces together in a way that really works for a veteran. So that's really kind of the main points we wanted to make here. In the VA, you know, we've taken care of, 1.9 million combat veterans over the past decade. We've tried to use this model, and Drew did a very nice job of saying, here's the way we looked at it, and then we tried to create a clinical system that reflected it, that isn't particularly complicated. I mean, if you have social workers, if you have behavioral health people, if you have medical providers, if you can connect them in a way that really provides a more integrated approach, it really works so much better for veterans. I was thrilled, John, that there are so many social workers here. Social work is the backbone for us, the backbone of post-deployment care, because they're a point of contact. They help to keep the system together. They coordinate care. And so hats off to the social workers that are here. And really hats off to all of you, whether you're in mental health, whether you're medical, whether you're not a clinician. We're all community members that need to do our part to make sure our veterans are cared for in the ways that they need. So thank you.